distinguished guests, ladies and gentlemen. It is indeed a great honor for me to welcome you all to the Myanmar Medical Virtual Online Conference on Improving Diagnosis and Management of Headache. Headache is one of the most common complaints encountered by the practicing physician and by any measure is one of the most prevalent symptoms in the general population. It represents the single most common reason for outpatient visit to the neurologist. Due to the myriad of potential causes, ranging from the benign to the catastrophic, headache seem to pose diagnostic and therapeutic challenges to the clinician. There has been an explosion of new knowledge about headache over the past 10 years. The mechanism of cephalic pain and the genetics of headache are better understood. New treatments have emerged based on the mechanism of headache. Numerous well-designed clinical trials are available using the headache classification system of the International Headache Society. A missed or delayed diagnosis of a primary headache disorder is unlikely to expose patients to life-threatening harm, but it does have consequences. It may mean that the patient doesn't have the benefit of new, highly effective treatment that work for some headache problems and not others. The first topic is on approach to headache, when to worry. This will be presented by Professor Dr. Pituitary, Professor and Head of Neurology Department, Yangon General Hospital, University of Medicine 1, Yangon. She graduated in 1987 and obtained Master of Medical Science, Internal Medicine in 1997, a doctorate in Neurology in 2007, Diploma in Medical Education on February 2018, and FRCP Edinburgh on March 2016, and FRCP Glasgow on October 2020. She was trained in clinical neurology at SEH in 2001 and neurophysiology training at University Malaya Medical Center, Malaysia in 2012. She had attended several workshops, training courses, and conferences, both local and international. At present, she is the chairman of the Academic Board of Doctorate Medicine, Doctorate in Neurology, University of Medicine 1, and she is a member of the Academic Board of University of Medicine 1, Yangon. She is also the member of the Academic Board of Master of Medical Science, Physical Medicine. She is a member of American Academy of Neurology, World Stroke Organization, European Stroke Organization, World Federation of Neurology, International Association of the Study of Pain, International League Against Epilepsy, Asia Pacific Stroke Organization, and International Movement Disorder Society. At present, she is the Vice President of Myanmar Neurology Society. May I invite Professor Pituitary for her presentation, please?
Good morning to you all, and thank you very much, Professor Micho, for your kind introduction. And in today's webinar, I'm going to discuss about the approach to headache, when to worry. And these are the contents of my talk. And the headache is defined as the pain in any part of the head, including the scalp and face, including the orbital, temporal, and the orbitotemporal area and the interior of the headache. And the headache is one of the most common reasons patients seek medical attention. And there is two types of the headache, and the primary and the secondary headache. And we can distinguish the primary from the secondary headache disorders by the finding out the presence of the reflex warning signs. And if there is no reflex signs, we can diagnose as the primary headache and give the treatment. If the patient with the atypical features and thorough investigations should be performed. If there is a reflex warning signs present, it is the secondary headaches and the thorough investigation should be done. And these are the primary headache disorders, for example, migraine and the tension type and the cluster headache, etc. And then the short-lasting unilateral neuralgiform headache, and the Hemicrania Continua. And these all are the primary types of the headaches. These are the secondary headaches, and there is a SAH, ICH, subdural hematoma, and the vasculitis, and the pituitary apoplexy, and the meningitis, encephalitis, and the brain tumors, etc. And in evaluation, we have to rule out the serious underlying pathology and look for the other secondary cause of the headache. So in the headache, the symptom, it is thoroughly in the history taking is very important. In the history, there is a sudden, the severe thunderclaps headache is very important to raise a suspicion of the SAH. And the other factors are also important, such as age, present or absence of the aura and prodrome, and the frequency and intensity and duration of the headache, and new or the severe headache, and number of headache days per month, and the previous headache history, now with the progressive or the significant change in the headache attack pattern, frequency, and severity. And the recent trauma, family history of the migraine, and the exacerbation or relief with a change in position, which is also important, and predominantly nocturnal or early morning headache was with a Varsova maneuver, which indicate the raised ICP. And also there is the carbon monoxide exposure and the past medical history of the carcinoma, HIV, TB, multiple sclerosis, and acute myocardial infarction to exclude the cardiac cephalogia. And the review of the current medications are also important in the history taking. And the one thing you have to bear in mind that the 77% of the patients with the headache secondary to the brain tumor meet the ICHD criteria for the tension type headache. And tension type headache is a diagnosis of the exclusion. And also the migraine is often misdiagnosed. And to identify the migraine, the following the questions should be asked and within the last 3 months. And the mnemonic is a PIN. And P is for the photophobia. Did light bother you a lot? And I means the incapacity. And did your headache limit your ability to work, study, or do what you needed to do for at least 1 day? And N for the nausea. And did you feel nauseated or sick to your stomach? And these are also the questions about the migrainous headache. And why is the migraine frequently mistaken for the tension type headache? Because 75% of the neck pain is common during migraine, and also the 40% of the migrainous headache is often bilateral. And the stress is a common migraine trigger, and also in the tension type headache. And comorbid depression and the anxiety obscure the diagnosis. And why is the migraine frequently mistaken for the sinus headache? And pain is often located over the sinuses, and the sinus medication may provide the relief to the migrainous headache. And migraine frequently triggered by the weather changes, and the sinus headache also associated with the weather changes. And tearing and nasal congestion is a common during the migrainous attack, and it is also the common symptoms in the sinus headache. How to differentiate between the migraine aura and the TIA? And in the migraine, there is a positive visual symptoms such as the halos, fortifications, and the spectrum of the white lights, and there is a zigzag and jigsaw puzzle patterns, etc. In TIA, there is a negative visual symptoms such as a visual loss. In migraine, there is a gradual onset and the evolution, and in TIA, which is the abrupt onset. And in migraine, it progressed sequentially, and in TIA, it occurred simultaneously. And in migraine, the duration up to the 60 minutes, and which followed the headache, that is 50%. And in TIA, the duration is rather the short, and that is less than 15 minutes, and headache is uncommon. And another thing you have to bear in mind that there is a thunderclaps headache, and there is a disorder that can present with the thunderclaps headache. These are the SAH and sentinel headache, ICH, and the subdural hematoma, the vasculitis, meningitis, encephalitis, and the other primary, the exertional and cough headache. In general examination, you have to test the conscious level, fever, meningism, papilledema, optic neuritis, new focal neurological deficit, and to take the blood pressure and pulse, listen the bruit and the palpate the head and neck, and examine the spine and the neck muscles. Regarding the neurologic examinations, you have to test the mental status testing, cranial nerve examination, fundoscopy and otoscopy, and the symmetry on the motor and the reflexes, and the cerebellar signs, and the sensory test. Regarding the gait examination, you can do the getting up from the seated position without any support and walking on tiptoes, and the heel tandem gait, and the Rombach test. This slide is showing the low-risk features, and the patients with a headache meet these criteria do not require the imaging. That is, the age less than 50 years, features typical or the primary headaches, and history of similar headache, no abnormal neurologic findings, no concerning change in their usual headache pattern, and no high-risk comorbid conditions, and no new or concerning findings of the history and examination. The majority of patients with the headache complaints have a completely normal physical and the neurologic examination, but some types of the primary headache with the specific abnormalities, such as the pericranial muscle tenderness in the tension type headache, and the hyperalgesia allodynia in the migrainous headache, and the autonomic symptoms in the Hemicrania Continua and the trigeminal autonomic cephalgias, and the if there is a danger sign of the reflex is noted, and you have to do the further evaluation. So it could, because of the it is a possible serious underlying disease. So mnemonic of the danger signs are the SNOOP 10. And this slide is showing the SNOOP 10 danger sign, that is a reflexes. As for the systemic symptom, including the fever, and there is a 2M, one N is a neoplasm history, the another N is a neurologic deficit, and there is 2O, one O is onset, and the another O is older age group, pattern change, and positional headache precipitated by the movements, papilledema, progressive headache, pregnancy, painful eye, post-traumatic onset, and the pathology of the immune system, and the painkillers overdose. And this slide is showing the specific features suggesting and the secondary headache source. And these specific features are the side lock pain, and the impaired vision or the seeing halos, and the short duration that do not meet the criteria for the migraine after age 50, and the rare adverse effects of the topiramate. It is a very rare condition. And the visual field defects, and the sudden severe unilateral visual loss, and the painful monocular visual loss. And there is a sign symptoms of the raised intracranial pressure, and another factor is obese women of the childbearing age, and there is with the papilledema, visual loss, and elevated LB opening pressure. That indicates the idiopathic intracranial hypertension. And the patient with the headache, which relieved with the recumbency and the exacerbated with the upright posture, it indicates the spontaneous intracranial hypotension. In the brain tumor, there is the signs and symptoms of risk ICP with the headache is more worsened with the with the movement, particularly the bending over. In case of the pheochromocytoma, there is a generalized sweating, the tachycardia, and the paroxysmal hypertension. And there is the conditions needed for the emergency evaluation. There's a thunderclap headache to exclude the SAH, and there is a neck pain, Horner syndrome, and the neurological deficit to exclude the cervical and the cervical and vertebral artery dissection. And there's a headache with the fever and meningism to exclude the meningitis and encephalitis. And in brain tumor, there is a neurological deficit or the papilledema. The features are headache with the orbital or the periorbital symptoms to exclude the acute enclosure glaucoma. And these are the investigations should do in the secondary headache. That is, these are the laboratory tests, LP, imaging, and neurophysiology testing, for example, EEG. And these are the indications for the imaging and the patient with the danger signs. And the second one is the recent onset headache that is the featureless. There is a choice of the imaging examination. There is two types of the imaging examination. One is an emergency setting and another is in the non-emergency setting. In the emergency setting, most life-threatening causes of the headache, such as the intracranial hemorrhage and tumor, are easily detected on the CT as an initial screening examination in the emergency setting. CT is highly sensitive for the hemorrhage. The upper CT is showing the SAH. It may be, it is due to the aneurysmal rupture. The lower CT is showing the ongoing ICH. The MRI is indicated and the optic edema or the trigeminal pain and the chronic headache with the U features or the headache in the context of the reflex. And in non-emergency setting, MRI is usually reserved as the non-emergent elective study, and it is more sensitive than the CT for the most secondary cause of the headache. For the imaging of the vessel, CTA and MRI can be done. And for the lumbar puncture, it is urgently indicated in the clinical suspicion of the SAH and with the normal head CT, and also a suspicion of the infections, inflammations, and neoplasm. And also LP is necessary in case of the suspected idiopathic intracranial hypertension, but it is not necessary in the MRI is consistent with the spontaneous intracranial hypertension. The take-home message is, emergency diagnosis and treatment is indicated for the sudden onset of the severe headache, that is a thunderclap headache, and the new headache with the suspected meningitis or encephalitis, and with the neck pain with the Horner syndrome suggesting the cervical artery dissection, and with the focal neurologic deficit or the papilledema suggesting the increased intracranial pressure. These are the references. And this is end of my presentation, and thank you very much for your attention.
Thank you, Professor Pituitary, for your excellent presentation. The second topic is on management of headache. This will be presented by Professor Dr. Mumuzo, Professor and Head of Neurology Department, North Okulapa General Hospital, University of Medicine 2, Yangon. She graduated on April 1994, obtained Master of Medical Science, Internal Medicine on December 2003, doctorate in neurology on December 2010, MRCP UK on November 2011, and FRCP Edinburgh in September 2016, and diploma in medical education on 2018. She took neurology training at Department of Neurology, YGH, and clinical neurophysiology training at University of Malaya Medical Center, Kuala Lumpur, Malaysia. She had attended several international workshops, training courses, and conferences, and she is a member of AAN, WFN, World Stroke Organization, International League Against Epilepsy, and International Movement Disorder Society. She is a committee member of Myanmar Epilepsy Initiative. Her special interests are in memory disorders and movement disorders. Now, may I invite Professor Mumuzo for her presentation, please.
Good morning, all the doctors and audience. I'm glad to hear, and it is also a great honor for me to take part in this headache symposium in 67 MMA conference. My topic is continuation of the approach to headache, how to tune the headache management. These are the topic outlines, and I would like to focus on general consideration in management of headache and new onset severe headache. So these new onset severe headache are mostly cover the secondary headache disorders. Regarding the general management of the headache, the following factors should be considered. Causes of new onset severe headache differs from that of a chronic recurrent headache, and potentially serious cause is more likely with a new severe headache. And while a life-threatening headache is relatively rare, caution is required to identify these cases. So we need to aware the reflex of headache previously mentioned by Prof. Chuchule. So regarding the new onset severe headache, we would like to mention that the subtopics. And headache due to the vascular disorders are among the vascular disorder. Subarachnoid hemorrhage is very common. And first thing, most of the doctors consider SAH, which when the patient comes in with thunderclap headache. So 25% of thunderclap headache are SAH. But one pitfall is that SAH, half of the SAH patients are present with transient or milder headache, not a thunderclap headache. Because of the sentinel bleed, small bleeds come out, seepage of the blood come out from the aneurysm, and then second bleed is a very torrential, and the second bleed caused the patient to succumb, and so this sentinel bleed causing the milder headache can give rise to the risk of delayed diagnosis. Another pitfall is when we consider the SAH, doctors are usually done the non-contrast CT urgent, but CT may be not 100% sensitive. CT may be normal due to small amount of hemorrhage. CT may be normal. Hemorrhage below the foramen magnum, CT may be normal, and too early CT cannot detect the hemorrhage, and too late, like that is a patient present after 2 weeks, CT and also CSF may be normal. So in these cases, we suspect the SAH, but CT head is normal. This is indicated to do the MRI and MR angiography or conventional angiography to detect the aneurysm and source of the bleeding. So management, when we detect the aneurysm, source of SAH, management is the surgical intervention, clipping or coiling. And we need adequate hydration is necessary. Another vascular disorder is subdural hematoma. These subdural hematoma is more insidious onset of headache, and classical features are patients are elderly, and they also not only in headache, but they usually present with change in mental status like confusion, lethargy, drowsiness, and some cognitive disorders. In subdural hematoma, when headache occur, initially blood is not too much, and gradually bloods are collected and giving rise to the midline shift. And This possibly cause the headache, and because of the result of the stretching of the pain-sensitive meninges and meningeal blood vessels. So treatment of subdural hematoma is totally surgical. Aspiration of hematoma can recover the patient fully recover the patient. So it is not to be missed, the subdural hematoma. Cervical arterial vessel dissection is not so common, but we think of this disorder when patient come in with neck pain as well as facial pain. So in the neck vessels, carotid artery and vertebral artery can dissection can occur. Both carotid and vertebral arterial dissection, 60 to 90% of patients suffer a headache. In carotid artery dissection, unilateral face and neck pain can occur. Also, Ono syndrome can be associated, and if there is a ischemia of the ophthalmic artery, amaurosis fugax can occur. These arterial dissection can be mistaken with migraine because of the Ono syndrome can misdiagnosed as cranial autonomic features, which usually occur in migraine and cluster headache. So, in vertebral arterial dissection, patients usually present with cerebellar sign, lower cranial neuropathy, and visual field defects. Treatment or option for cervical arterial dissection is antiplatelet therapy, or other options are antithrombotic therapy, thrombolytic endovascular, and very rarely surgery. Because in arterial dissection, blood are not present in the lumen and blood are clotted, and they are collected between the layers of the arterial walls. Another vascular disorder, we usually found 1/3 of the ischemic stroke patients suffer headache. And treatment is, according to the guideline, acute stroke treatment. If patient come in with window period, 4.5 hours, we can, any indication, contraindication, and criteria are fulfilled, we give the RTPA. If beyond the golden hours, patient we treated with antiplatelets. Another vascular disorder is now cerebral venous sinus thrombosis. It is now more common in our population. And headache in cerebral venous sinus thrombosis is most common, but least specific features. If we are detected the CVT by MRV or MRV, and CT finding is not so specific, so or management or choice, investigation or choice is MRV. And if we found diagnose the CVT, treat as the subcutaneous heparin and anticoagulants. This one is arterial hypertension. In this case, patients are usually diagnosed their own diagnosed as hypertension and present to the doctors. So tomorrow, I conquite three auto conquite lali shijare. The 3 diagnosis, 3 shin. But arterial hypertension not necessarily cause the headache. When headache occurs, headache may appear as a result of severe arterial hypertension equal or more than pressure more than 180 by 120 millimeter mercury, grade 3 hypertensions. To diagnose the headache is due to the arterial hypertension, there must be temporal evidence of causation with development of the headache at the onset of hypertension, and significant worsening of headache may be parallel with worsening of the hypertension. Another subheading is the headache due to the infections. If patient come with headache, fever, neck stiffness, and chronic Brudensky sign, it must do further evaluation because it indicates the CNS infection, meningism. And we have to proceed a brain imaging followed by lumbar puncture and followed by empiric parenteral antibiotics while awaiting the CSF results. Immunosuppressed patients, elderly and pediatric populations are high risk to get the CNS infection, and also meningism is not obviously revealed in these populations. These meningitis symptoms can be mistaken with those of migraine because patients suffer nausea, vomiting, and photophobia. Headache due to inflammatory disorder, I would like to focus on, highlight on giant cell arteritis. These disorder classical symptom is elderly come in with temporal artery tenderness, shallow temporal artery pulsation, and scalp tenderness. Also associated with anorexia, marked weight loss, and lethargy. So, we suspect the giant cell arteritis. We go on to do the blood tests like ESR and CRP found to be high. Management is high dose glucocorticoid significantly improve within a few days, and headache improve within few days, and also glucocorticoid is necessary to prevent the blindness because giant cell ophthalmic artery involved, it can lead to the blindness. Another pitfall in diagnosis of giant cell arteritis is arterial biopsy usually get a false negative when it's taken from the skip area and length of the artery is not adequate. Another one, Tolosa-Hens syndrome. It is also gives sometimes the headache to the physicians. It's coming with a severe unilateral periorbital headache associated with painful ophthalmoplegia, but its cause is relaxing remitting, and pupillary abnormalities can also occur. So contrast-enhanced MRI may demonstrate granulomatous inflammation of the cavernous sinus, superior orbitofascial orbit. Treatment is with high-dose glucocorticoid can significantly reduce the pain within a few days, but we need to be careful about the other infection and fungal infection of in this area, cavernous sinus and orbit. We need to exclude the infection because glucocorticoids can worsen the infection, fungal infection, or other infections. Headache secondary to ENT disorder, like in other craniofacial structures. Among them, acute ankylosing glaucoma is most important. If you suspect the glaucoma, urgent referral to ophthalmology is necessary to prevent the blindness. In acute ankylosing glaucoma, severe headache and eye pain can result from intermittent ankylosing glaucoma lead to significant rise in intraocular pressure. Acute ankylosing glaucoma can be mistaken with migraine because of the similar symptoms like nausea, vomiting, light sensitivity, and rainbow color halos around the light. Trigger for the ankylosing, in the history, we also asked about the triggers of ankylosing, like a prolonged reading, and some medication need to be keep in mind that anti-cold, anti-allergic drugs, tricyclic antidepressants, acetazolamide, and topiramate can cause the ankylosing glaucoma because topiramate is used in migraine and other headache disorder. So we need to detect the drug history. Trochleitis is the inflammation of the trochlea. Trochlea is a cartilaginous apparatus. In this case, it is rare, but in this trochleitis, causing the localized supranasal pain and tenderness around the orbit and worsen with eye movement. But treatment of trochleitis is NSAID, or NSAID usually alleviate the pains. If not relief with NSAID, another option is oral steroid or locally injected steroid can relieve the pain. Rhinosinusitis is also common. Sinusitis causes de novo headache as well as facial pain, and it's also exacerbates the primary headache disorder already established in the same patients. This rhinosinusitis symptoms can also confuse with the migraine symptoms because it's lacrimation, nasal congestion, and rhinorrhea can be misdiagnosed as migraines. For diagnosis of rhinosinusitis, international classification or headache disorder diagnostic criteria include the clinical as well as nasal endoscopic imaging for acute attack. For the chronic rhinosinusitis, previous as well as current attack of infection need to be established. Headache due to temporal mandibular joint disorder. TM joint disorder associated pain is mediated via the sensitive joint capsule and posterior disc attachment, and pain is transmitted by nociceptive signals via the trigeminal nerve. So TM joint disorder pain is from joint as well as muscles and fascias. So management and diagnosis of the TM joint disorder need clinical, temporal relationship, and radiological evidence of TM joint pathology. Headache due to trauma. In post-traumatic headache now became more and more recognized and more prevalent. And observation at 1 year after event, moderate to severe traumatic brain injury, or 70% of patients suffer headache. After mild traumatic brain injury, 91% suffer the headache. So we call the acute post-traumatic headache when headache occurs during the first 3 months after onset, but it passes beyond the treatment. We call persistent post-traumatic headache. Treatment is according to the presenting phenotype. Some present with migrainous type, or some present with the tension headache type, the whole head. So we give the empiric treated toward the presenting phenotype, but robust evidence to relieve the pain is still lacking. Post-craniotomy headache pathophysiology is similar as the post-traumatic headache, but mechanism is still unclear. The last one is headache due to neoplasm. These headache are both physician, doctors, as well as patients concerned for that headache. If the patients suffer from headache and not relief and passes for more than a week, they are concerned for brain neoplasm, brain tumor. But actually, brain neoplasm less frequently present with severe headache. 1/3 of the patient with brain tumor report headache on presentations. Type of the headache is exacerbation with exertion. Headache was in change in posture, awakening the patient from sleep, and abrupt change in pattern of prior headache disorder. So we need to be aware, reflex sign of the headache. So finally, take-home message is secondary causes of headache are diverse. Majority are benign. To differentiate benign from the malignant sinister headache, a thorough history taking for headache as well as related medical history, drug history, and careful neurological examination can help to determine and whether necessary or not the further laboratory tests and expensive brain imagings. Thank you for our kind attention.
Thank you, Professor Mumuzo, for your very interesting presentation. The third speaker is Dr. Pravin Thomas, who is a consultant neurologist and lead of headache medicine, Basildon and Thurrock University Hospital, NHS Foundation Trust UK, and he is an honorary clinical teaching fellow, Queen Square Institute of Neurology, an associate editor of Annals of the Indian Academy of Neurology, and he is the founder of Chief Executive and Treasurer of World Headache Society. His topic is on migraine mimics. Thank you so much for joining us at this early hour, Dr. Pravin, to present these very interesting topics to broaden our knowledge. May I invite Dr. Pravin Thomas for your presentation, please?
Hello, everyone. My name is Pravin Thomas. I'm a neurologist and a headache specialist. I'm also the founder and chairman of the World Headache Society. I thank Dr. Momo Zor and the Myanmar Neurological Society, MMA, for inviting me to this lecture. I'm going to be talking to you about migraine mimics. Now, mimics are alternative diagnoses. They pose as migraines, but they're not really migraines. Now, every stage of migraine can have a mimic. Prodromes, which are non-headache symptoms, which can begin up to 2 days before a migraine episode, just like an aura, can occur before, during, or after the migraine attacks. Now, each of the prodrome symptoms that you see on the screen open up a differential diagnosis of several neurological conditions, for example, fibromyalgia. But the recurrent nature and the pattern helps us to consider this within the migraine spectrum. Now, these are the conditions which can mimic migraines: stroke, tumor, meningoencephalitis, epilepsy, demyelation, and sometimes even conversion. Now, an important mimic of migraine is Hemicrania Continua, which is unilateral, continuous, and daily with moderate to severe intensity. Now, 40% of Hemicrania Continua fulfills migraine criteria during the Hemicrania Continua exacerbations. And this is important to recognize because Hemicrania Continua is responsive to indomethacin. Now, all migraine auras can also be found in TIAs and epilepsy as well. Important differentiating points are the elementary or unformed nature and the variable positions in migraine, whereas TIAs conform to a vascular territory and therefore doesn't change positions often. And the epileptic auras tend to be more complex. An example is a simple abdominal discomfort and belching in migraine versus a rising epigastric sensation in temporal lobe epilepsy. Now, Charles-Bonnet syndrome presents with a simple to complex visual hallucinations. They are differentiated by the field defect in the region of the hallucinations due to the prior occipital stroke. And prosopagnosia with object agnosia and amnesia are generally associated with epilepsy. Dysphagia in migraine is slowly progressive, and multiple language and speech domains are affected, along with previous episodes and migraine accompaniments. And generally, the auras tend to be progressive, involving one cognitive domain followed by the other, rather than all of them together at the same time, as in a TIA. Now, presyncope and syncope are associated with migraine and may present as a dimming of vision and a brief loss of consciousness. Postural dizziness may be associated with POTS and Ehlers-Danlos syndrome with migraine, and they are present only on sitting or standing. Orthostatic tremors is an aura mimic that occur on standing, and it reduces on continuing to walk. True benign positional paroxysmal vertigo is related to changing head position. Now, TIAs tend to have an abrupt onset, even though they may stutter or stagger. And most importantly, there is a concurrent involvement of all the affected modalities at the onset. Unlike migraine, where there's a shift from one modality to the other and slowly, as I mentioned before. For example, a visual aura is followed by a sensory aura in migraine. Also, majority of TIAs usually last only a few minutes. Now, migraines can have cranial autonomic symptoms, whereas trigeminal autonomic cephalalgias can have migraine symptoms. Sometimes TACs and migraine can overlap in the same individual. The most important differentiating feature is the urge to move in TACs. Now, both cluster headaches and migraines can respond to oxygen and sumatriptan injection, and therefore, it doesn't really help to differentiate between the conditions. Somatosensory aura can have a pseudo-peripheral nerve pattern in a single limb, or a cord or a brainstem pattern with all the four limbs or the face involved. Optic neuritis can also present with blurred vision and sensitivity to light. It's the pain on eye movements and the loss of color vision and progressive loss of visual deficit that are helpful in clinically distinguishing optic neuritis. Migrainous headaches can occur in up to 80% of newly diagnosed clinically isolated syndromes and MS. MS patients may also have short-lasting paroxysms of dysarthria and ataxia, but they are usually less than 1 minute. Hypnic headaches are typically shorter than 4 hours and is a wake-up headaches. They reduce as the day progresses. They may be migraine type in about 1/3. Also, 70% of hypnic headaches had a history of migraines, and therefore they can coexist. And some of them are caffeine responsive, though the treatment is basically to take a cup of coffee at night as treatment for hypnic headaches. Now, other causes of wake-up headaches include IIH, that's idiopathic intracranial hypertension, sleep apnea, nocturnal hypertension, and hypoglycemia, and medication overuse headache, exploding head syndrome, and mid-rostral pontine lesions. Migraines can present as confusion, unexplained falls, and transient facial asymmetry. Isolated vertigo, dysarthria, and diplopia can occur with posterior circulation strokes. Although PFOs have been associated with migraine, there is no improvement in migraines with a PFO closure. Now, CT perfusion abnormalities may be found in 12% of patients with migraine with aura. Also, aphasia is a common symptom of patients with migraine with aura with CT perfusion abnormalities, alterations. The CTP pattern may be unilateral, but they do not respect a vascular territory. And also, CTP abnormalities may be found in prolonged seizures. Now, there are some outliers in any medical condition. One of them is a facial migraine, where they can just have facial pain with some migrainous features like nausea or an aura or photophobia. However, the face is an atypical location and it shares the borderland with atypical facial pains. A transient global amnesia is characterized by acute onset of an anterograde amnesia, and they last for a few hours. Migrainous TGAs share the borderline with epilepsy. So there is an overlap between epilepsy, TIA, and psychogenic amnesia. Now, one of the ways to differentiate is that migrainous TGA is more common in middle-aged women, and they last longer than the epileptic TGA and is associated with nausea or dizziness. And the chance of recurrence is rare if it's epileptic versus a migraine. The chance of recurrence is rare in sort of these TGAs as opposed to, let's say, someone who has got a common form of TGA recurrence like in epilepsies. Now, the autonomic circuit involvement can present with cranial autonomic symptoms like puffy eyelids, watering from the eyes or nose, and vascular autonomic abnormalities like sweating, hypertension or hypotension, and GI autonomic like vomiting and diarrhea. Autonomic symptoms leading to syncope are more common, especially when they're associated with Ehlers-Danlos syndrome and hypermobility syndromes. Mitochondrial disorders can be associated with migraine and encephalopathy along with other deficits. Cadacil may present with migrainous headaches, strokes, and encephalopathy. Familial hemiplegic migraine can have a clinical overlap in certain patients with episodic ataxia type 2, spinocerebellar ataxia type 6, benign familial infantile epilepsy, and alternating hemiplegia of childhood, all of which is a channelopathy. Now, migraine aura can be followed by epilepsy within 1 hour, and these conditions called migralepsy, they tend to have a genetic basis, and both tend to be having a channelopathy. Prolonged aura can lead to infarction and may leave a fixed deficit. Occipital epilepsy is present with short-lasting, rapid onset, rapid offset, colored and circular auras, in contrast to migraine auras, which are longer, gradual onset and offset, black and white and linear or zigzag. Now, to summarize, migraine can occupy the borderline with syncope and epilepsy. Ehlers-Danlos syndrome may be associated with migraine POTS. Migraine may be followed by epilepsy. Epilepsy may be followed by migraine. And prolonged syncope can lead to seizures and may be followed by migraine. And Meniere's disease usually have a fixed hearing loss, which differentiates it from migraine. Now, idiopathic stabbing headaches are associated with migraines. Chronic migraine may be associated with a greater occipital neuralgia, which may be associated with occipital allodynia. Greater occipital neuralgia pains may refer to the back of the eyes. Like sensory allodynia, long-standing myalgia may present as cervical and shoulder pains with associated myofascial tender points. Episodic migraines can change to chronic migraines. IIH and CSF leaks can change to a migraine phenotype. Migraine may also later change to other syndromes of chronic fatigue syndrome, vestibular dysfunction, TAC, and also epilepsy. Epileptic aura is usually stereotyped. Epilepsy can behave as a mimic or as an outlier, or sometimes even as a chameleon, which changes colors. Now, migrainous headaches can occur pre-ictally in about 5 to 15%, ictally in about 5%, and post-ictally in about 50% of patients with epilepsy. Limb pains can be a part of migraines, and in children may be mistaken for growing pains or bone pathology, and in adults with fibromyalgia. Now, there are some catastrophic presentations, and they, you can call them as these dragon, or they could be sinister causes of acute severe headache. Now, some dragons are benign and spit smoke instead of fire. Now, these benign or idiopathic thunderclap headaches, they are sudden and peaking in 30 seconds, lasting for hours or weeks, and rarely they recur, and they're precipitated by exercise or sexual intercourse. Hypothyroidism and hypoglycemia can cause migrainous headaches and need a high index of suspicion. Now, some dragons can be catastrophic, as I mentioned. Vascular disorders may be related to migraines. Ipsilateral neck pain, headache for up to 4 days. Horner syndrome is encountered in carotid dissection. New onset migraines, worsening migraines may be the only feature of a hypertensive crisis. Pituitary infarction may be associated with photophobia and CSF pleocytosis. CVT may present purely as a migraine and rarely even with an aura. Headache may be the only symptom in 14% of patients with a cortical venous sinus thrombosis. Recent persistent headache, especially worsened on lying down and Valsalva maneuvers, should alert someone for the possibility of a CVT. Now, headache brought on by exercise and relieved by rest may be an anginal equivalent and may occur at rest in unstable anginas. Interestingly, about 30% of cardiac cephalalgias may be associated with photophobia, phonophobia, osmophobia, and nausea. Reversible cerebral vasoconstriction syndrome is typically a recurrent bilateral thunderclap headache with an identifiable cause like pregnancy or vasoactive drugs in 2/3 of patients. Vasoconstriction that reverses within 3 months may be associated with nausea and vomiting, photophobia, visual blurring, scotomas, or blindness. Temporal arteritis may be associated with throbbing unilateral headaches and rarely scintillating scotomas. AV malformations may be associated with migraine-like headaches, and they may have occipital auras which present like a visual aura, and 50% of AVMs present with headaches without any hemorrhage. Now, after radiation therapy, migraine-like headaches may occur for 2 to 3 months, associated with other neurological symptoms and signs, and that's called the SMART syndrome. Secreting pituitary tumors with symptoms of hyperpituitarism like growing feet and galactorrhea may be the only clue, and pituitary hemorrhages may be associated with a thunderclap hemorrhage. The non-secreting pituitary tumors may present with just migraine-like headaches. Migraine-like headaches may occur in up to 15% of patients with primary and metastatic tumors. Raised ICP symptoms may not be present at the early stage. Meningitis may trigger migraine-like headaches. Dental infections may also present with a referral headache. Migraine and sinusitis may present with facial pain, nasal and postnasal drip. Sphenoid sinusitis may be associated with a periorbital pain and may also be exacerbated by straining. But fever is present in more than 50% and purulent nasal discharge in 40% of patients with sinusitis. Now, headache associated with neurological deficits and CSF lymphocytosis is associated with migraine-like headaches and may also have sensory and motor symptoms and language disorders. Now, this Handel syndrome is characterized by elevated lumbar puncture opening pressure, and the CSF shows a lymphocytic pleocytosis with raised protein. If there is an agitated delirium in this spectrum, you have to suspect an NMDA encephalitis. It's very important not to miss high and low CSF pressure headaches. Most notably, they are postural. However, the postural symptoms become less obvious over time. IIH may have pain on lying for a long time, pulsatile tinnitus and papilledema. The low CSF pressure headaches are brought about in an upright position due to the brain sag due to gravity. Low CSF pressure headaches may also be affected by cognitive and movement disorders, and CSF pressure sometimes varies between high and low, especially if there's a mobile cyst. In such cases, a continuous ICP monitoring may be required. IIH without papilledema is based on clinical and radiological features. IIH is almost always associated with obesity. A practical approach, we are nearing the end of the presentation, and let's take an outline, a lucid and practical clinical approach to these conditions. Now, clinical history, the SNOOP-10 is a useful checklist. It's available if you could just search for SNOOP-10 to look for the red flags. And in clinical examination, do not miss blood pressure and heart rate, hypertension, hypotension, and tachycardia in POTS or bradycardia in raised ICP. Do not miss examining the eyes for papilledema in IIH and raised ICP due to other causes, Horner syndrome in cervical artery dissection, nystagmus in vestibular migraines and strokes. Bruit in cavernous sinus fistulas, carotid and vertebral artery bruit in strokes, temporal artery pulsation absence and temporal artery tenderness in temporal arteritis, and also cervical spine tenderness and gone tenderness of allodynia. So a pathway would begin with any change from the usual migraine features based on the history and examination to rule out the red and the orange flags. Now, if headache persists, identify the triggers and trauma, and also rule out possible medication or substance overuse. Thank you very much for your patient hearing. Once again, thank you, Dr. Momozo, and the Myanmar Neurological Society, MMA, for inviting me, and I encourage you to enroll in the World Headache Society, All India Institute of Medical Sciences, New Delhi, Headache Medicine Distance Learning Certification with a later eligibility to earn the fellowship of the World Headache Society. And this is the website, www.worldheadachesociety.org. Once again, thank you very much.
Thank you so much, Dr. Pravin Thomas, for your very interesting and informative presentation. And this is the time for question and answer. I think that's a question. Yeah. Can post-traumatic headache and Mr. Dr. Pravin Thomas, there is one question for you. Can post-traumatic headache be a migrainous headache?
So certainly, yes. I mean, post-traumatic headaches can manifest as any of the primary headache disorders. And therefore, their features can be having migraines, tension-type headaches, and even the trigeminal autonomic phalanges. So it's one of the challenges basically is trying to treat post-traumatic headaches. That's probably it's a nightmare for a headache specialist to be confronted with post-traumatic headaches, which just go on despite a lot of measures.
How to monitor?
That's why we tend to encourage a lot of therapy, meditation, yoga, everything incorporated as sort of integrative medicine. And in my experience, a lot of people who have had some improvement with botulinum toxin injections, and they tend to have a better responses in their mental health as well. So you have to take in most of them tend to have a lot of psychological comorbidities as well. But there can be a nagging problem, so it has to be a multidisciplinary approach.
Thank you. Another question is, one doctor asked, how to monitor giant cell arteritis, ESR or symptoms?
Certainly, one of the measures is to go for ESR. Symptoms would be one of the earliest improvements would be basically in symptoms the moment you start with steroids. the difficult part is basically to decide on when to stop it. I mean, you could have a normal ESR after 2 years, and you might want to try to stop it for a while and then keep a watch on the symptoms. So it's really a combination, but once you start it, you would eventually be continuing it for at least a year. So therefore, there is not necessity to have a frequent monitoring of ESR, but what should be monitored is more the symptoms of the patient. So if the symptoms of the patient worsen, then you might think that there is something else going on, or the immunosuppression is not sufficient.
Is there any question?
I'm sorry, I think whether I was audible or not, because someone had said they couldn't hear. So I was trying to say about the duration of the treatment. And so the symptoms enough is basically to say that whether the immunosuppression is enough. And you would be continuing it. Eventually, you'd be asking the patients to come back to you if there's any sort of worsening, in which case you might want to repeat the ESR and to see if it's gone down or not. But otherwise, if you just follow the standard protocol that we use for temporal arteritis treatments, you would notice that there is a significant improvement. If there is no improvement, then you need to revise your diagnosis or think that the immunosuppression dose that you're giving is not sufficient.
Thank you, Dr. Pravin Thomas.
Thank you.
There is no more question. I would like to thank all the speakers, Professor Pipule, Professor Mumuzo, and Dr. Pravin Thomas, for their very informative and excellent presentation, and also to the audience for giving their precious time for attending this webinar and participating in discussion. And last but not the least, I'm very grateful to Zydus Caregiver for their help to accomplish this mission by sponsoring this webinar. Thank you so much, Dr. Pravin Thomas.
Thank you, Professor Cho, Professor Fu, and Professor Momoso. Thanks so much for having me here. And it was really nice to interact with all of you. And I wish you all the very best. Thank you very much. Look forward to seeing you.
Stay safe and healthy.
Yes.
Yeah.
Yes. You too. Take care.
Yeah.
See you soon.
Thank
Be in
you.
touch.
Yeah.
Yes, I'll email you. Thank you very much. Take care.
Yeah.
God bless.
Bye-bye. Yeah.
Bye.